All right, so you're someone who really wants to get to the bottom of things, right? I mean, like,
Yeah.
you want to really understand complex topics, but you also want to do it, like, efficiently. You don't want to be digging through mountains of info, and that is exactly what we're doing today. Today we're going deep, a deep dive into acute coronary syndrome, ACS for short.
Yeah. Think of it as sort of like a fast track to understanding a really crucial part of of health, right?
Yeah.
We've got these really detailed medical documents, excerpts,
Yeah.
and we're gonna. Well, our mission here is to pull out the most important stuff about ECS, what it is, the why, how it's spotted, and the big one, how it's managed.
Gotcha. So acute coronary syndrome, I mean, that sounds pretty serious. And it's not just one thing, right? It's kind of like a blanket term.
Yeah, exactly. ACS, that's our umbrella. And under it, you find things like unstable angina and, acute myocardial infarction, often just called MI. But then, and this is where it gets a little more nuanced, MI itself has two main types, STEMI and NSTEMI.
Okay, so we definitely need to sort those out. Let's start with the basics. Unstable angina versus a myocardial infarction. What's the big difference there?
Okay, so with unstable angina, someone has chest pain angina, right? And it starts to change. Like it's getting worse. Maybe it happens more often or with less effort, maybe even when they're just, resting. But the key here, the big difference, no actual damage to the heart muscle itself. It's a warning sign, but not the damage itself.
But a myocardial infarction, that is the damage, right, to the
Yeah,
heart.
exactly. And MI, it happens when those chest pain symptoms are there, even at rest. And this time, there's proof, like evidence, that heart muscle cells have actually died. And we see this, we detect it because of raised levels of cardiac biomarkers. It's like, imagine there's substances released by these damaged cells. They go into the bloodstream, and it's like, oh, they're an SOS.
And then we've got STEMI and STEMI. They sound really similar. What's the thing that makes them, different?
The core difference is what you see on an electrocardiogram, ECG.
Yeah.
It's like a recording of your heart's electrical activity. And also whether those cardiac enzymes we just talked about, if they're high. So in STEMI, that stands for ST segment elevation myocardial infarction. There's a specific part of that ECG, this tracing. It's called, the ST segment.
Mm-hmm.
And it shows, it has this persistent kind of spike in elevation. And yeah, those cardiac enzymes, they're up too. They're elevated, confirming the damage.
So that spike, that persistent spike on the ECG, that's our big red flag for STEMI, right?
Yeah, pretty much.
What about in STEMI? What's going on there?
Within STEMI, that's non-ST segment elevation myocardial infarction.
Right.
You won't see that same persistent spike on the ECG. But, and this is important, the cardiac enzymes are still elevated, like in STEMI. That means there's definitely been damage to the heart muscle. And then there's unstable angina, where you don't have that ECG spike, and those enzymes, they're normal.
That's actually a really clear way to put it. STEMI is like a yes to both the ECG thing and the enzymes. And STEMI, no spike on the ECG, but yes to the enzymes. Unstable angina is a no to both. So it kind of lays it all out, right?
So it's like a little checklist almost.
Exactly. So what is it that causes all of this to happen? I mean, what's going on in the body that sets off these, ACS events?
In most cases, the vast, vast majority of ACS, the root of it all, is a blocked coronary artery. And that blockage, it's usually because of a blood clot. We call that a thrombus, forms right there in the artery.
Okay, a blood clot. Got it. But I guess, what makes these clots form, and how does the size of it or how much is blocking, how does that tie into the different types of ACS we just talked about?
That's what's really interesting in these medical papers. It's how much that artery's blocked and how that lines up with which ACS you see. So unstable angina, you might have a clot, but it's small. It doesn't block the whole artery. Within STEMI, usually a partial blockage. The clot's there, but it's not fully blocking things. But in STEMI, that's where it's serious. It's almost always a complete blockage. The whole coronary artery blocked by that clot. And that's what causes that big spike on the ECG, and it means more heart muscle damage.
Oh, I see. So that blockage, how bad it is, that matches up with how serious things look on the ECG. So total blockage, big change on the ECG. Partial blockage, damage shown by the enzymes, but not that same ECG finding. Small blockage, just the warning signs of unstable angina.
You got it.
All right. So who is more likely to experience one of these ACS events? What are the things that put people at risk?
We can divide risk factors into two groups, right? The ones we can't change, those are non-modifiable, and then the ones we can potentially do something about, the modifiable ones.
Right. Okay. So non-modifiable first. What are those?
So those are things like getting older, being male, and family history. If heart disease runs in your family, that's a risk factor you can't change.
Yeah, those are kind of preset. But what about the things that people can, actually do something about?
Those are the modifiable ones, and that's where lifestyle changes and, medical management, it can really make a difference. These are things like smoking, drinking too much alcohol, not getting enough exercise. You've got high blood pressure, that's hypertension. And then there's type 2 diabetes, high cholesterol, that's dyslipidemias, and of course, obesity. Those are all things that can really increase your risk of ACS.
Okay.
And it's interesting, some recent studies, these medical documents highlight them. They show that early onset type 2 diabetes might actually be linked to more serious ACS events, especially in younger people, even more than we thought before.
Wow, that's pretty sobering.
Yeah, it is.
So working on those modifiable factors, those things you can change, it's super important for prevention. Okay.
But let's say someone does have an ACS event. What could happen? I mean, what are the serious consequences if it's not caught and treated quickly?
Yeah, that's the tough part. ACS can lead to some pretty serious complications. One of the big ones is heart failure. That's where the heart muscle, it gets weaker, it can't pump blood effectively. Arrhythmias are another one. That's irregular heartbeats, and those can be life-threatening. Ventricular fibrillation is one of those. It's basically chaos in the heart's electrical system.
Hmm.
It can cause sudden death, sometimes within the first hour of symptoms.
Wow.
Yeah. And sadly, someone who has had one ACS event is more likely to have another. It's called reinfarction.
Okay, those are really serious outcomes. So how would someone even know? Like, how would they know if they might be having an ACS event? What are the signs to watch out for most often? The most common symptom is chest pain, right in the center of the chest. Kind of like angina, but there are some important differences. This pain, it usually happens even when someone's resting. It's more intense, it lasts longer, sometimes for many minutes, even hours.
So not just like a quick pain that goes away quickly?
No, it sticks around, and it's bad. And this chest pain, it can come with other things too, like nausea, vomiting, sweating. That's what we call diaphoresis, shortness of breath too. And remember what we talked about with those complications. Sudden death, that can be the very first sign, sometimes the only one.
So it's definitely not something to ignore, right?
No, not at all.
Okay. So if someone has those kinds of symptoms, what do doctors do? How do they figure out if it's ACS, and if it is, what type?
The diagnosis really depends on two things, the ECG, the electrocardiogram, and then those biochemical markers, the blood tests for the cardiac enzymes.
The documents really emphasize that ECG needs to happen fast.
Yeah, for sure. Ideally, an ECG within 10 minutes, tops, of the patient getting to the hospital. That's vital. It's how you catch those ST segment changes that point to a STEMI. Think of the ECG like a graph. It's showing your heart's electrical activity. In a STEMI, a specific part of that graph, the ST segment, has that spike, that elevation, and that means there's a major blockage. The ECG can also tell you where the infarction is, like in the heart. Is it anterior, lateral, inferior, or posterior?
Wait, the location of the infarction matters.
Oh, yeah, definitely. An anterior wall infarction, for example, that one's got a higher risk of things like left ventricular failure and cardiogenic shock. That's when the heart can't pump enough blood. It's bad news. But, and this is important, some folks who are having myocardial ischemia, that means reduced blood flow to the heart muscle, they might not have any changes on that first ECG. So that's when those biochemical markers, those blood tests, they come in.
Gotcha. So the blood tests, they look for those cardiac enzymes. That's the other big piece of the puzzle when you're diagnosing. So these enzymes, it's like the heart's way of calling for help when it's been damaged.
Exactly. When heart cells get injured or die, they release these enzymes into the bloodstream. And we're looking for specific ones. Troponins, TNI, and also creatine kinase myocardial band, that's CK-MB. Those troponins, they're super specific for heart muscle damage. They're the best way to diagnose an acute MI. So even if the ECG doesn't show those STEMI patterns, those enzyme levels, they'll be high if there's been damage.
Got it. So ECG right away, especially for STEMI. And then blood tests to check for that heart muscle damage for any MI. All right. So let's say you've got an ACS diagnosis. What's the plan? What are you trying to do to treat it?
The treatment, it's all about a few key goals. Number one, this is the most important one, you got to restore blood flow to that blocked artery fast. If it's an MI, that helps minimize more damage. For unstable angina, it's about stopping it from turning into a full-blown MI. You also want to prevent, death and other complications. Make sure that artery doesn't block up again. That's reocclusion. And of course, help with the chest pain.
Makes sense. So how do they reestablish blood flow right away? I saw something about procedures in the materials.
Yeah. So for STEMI, the best option, if the patient gets to the hospital within 12 hours of those symptoms starting, is PCI. That's percutaneous coronary intervention. You can think of it as a way to open up that blocked artery, but it's minimally invasive. They thread this thin tube, usually through an artery in the wrist or groin, and they go up to that blocked coronary artery. Then they inflate a tiny balloon, it squishes the blockage, and they often put in a stent. It's a tiny mesh tube that keeps the artery open. Yeah, and these documents, they stress how important that time frame is for PCI. Every minute you wait, it's more risk of permanent damage to the heart muscle. It's really got to happen fast.
So that's like a direct way to fix the blockage.
Yeah.
What about NSTEMI and unstable angina? Is it the same? Did they do the same thing right away?
For NSTEMI, they usually go for an early invasive strategy, so either PCI or CABG, that's coronary artery bypass grafting. CEG is more involved. It's a surgery where they take a healthy blood vessel from somewhere else in the body and basically build a detour around that blocked artery. So yeah, it's a bit different from STEMI, where the focus is on that really fast PCI, if it's possible within that critical window.
Okay, so STEMI, often it's straight to PCI, and the STEMI, it's PCI or a bypass.
Yeah.
What about meds? I know there are a lot of different medications for heart problems.
Right, medications, they're huge. They're used for both the immediate situation and for managing things long term. So for STEMI, and usually for unstable angina and NSTEMI too, although there's one big exception, but we'll get to that, there are a few types of meds they give right away. Oxygen, if the patient's oxygen saturation is low, under 90%. Morphine can be used for the pain, and it can help reduce the strain on the heart by widening those blood vessels. But important note here, it helps with the symptoms, but it doesn't actually lower the risk of dying.
I'm guessing nitroglycerin is a common one for chest pain.
You bet. Those little sublingual nitroglycerin tablets, the ones you put under your tongue, they're usually given as soon as the patient arrives. And if the chest pain's still there, or they have heart failure, or their blood pressure's out of control, they might start IV nitroglycerin. Usually keep that going for about 24 hours after the pain's gone.
Okay, what about those fibrinolytic agents? Like, I saw alteplase mentioned.
All right, so fibrinolytic therapy. That uses meds like alteplase, retinoplase, tenecteplase, that's specifically for STEMI. These are powerful drugs. They bust clots. And they can be used in the first 12 hours after symptoms start if they can't do that PCI quickly.
So like a backup plan?
Yeah, kind of. Alteplase, for example. It has a specific way they give it, an initial injection, then continuous infusions over a certain time.
And it's only for STEMI, right? That fibrinolytic therapy.
Exactly. Never used for NSTEMI. That's super important.
Got it. STEMI, maybe fibrinolytic if PCI is not an option. And STEMI, never fibrinolytic. How about those antiplatelet and anticoagulant medications? That was a pretty long list.
Those are crucial. They prevent more clots from forming.
Yeah.
Aspirin is a big one. They give a high dose at first within 24 hours, then a lower daily dose, and they usually stay on that forever. Then there are the PDE-12 receptor inhibitors. Those are drugs like clopidogrel, prasugrel, and ticagrelor. All STEMI patients get those along with aspirin. They usually start with a big dose, a loading dose to get it working fast, and then a daily dose after that.
So it's like a 1-2 punch with aspirin and one of those P2Y12 inhibitors.
Right. And there are also glycoprotein IBEA receptor inhibitors. They might use those during a PCI in STEMI patients who are also getting unfractionated heparin. That's an anticoagulant. And speaking of anticoagulants, drugs like unfractionated heparin, bivalirudin, or enoxaparin, they usually start those in the ER, and they keep them going for at least 48 hours, sometimes longer. They stop the clot from getting bigger and prevent new ones.
Okay.
Unfractionated heparin, that one's given through an IV, first a bolus, then a continuous infusion. Enoxaparin, that's an injection twice a day.
Wow, that's a lot of meds right away. What else do they do in those first few hours?
They also usually give beta blockers early on, within the first 24 hours for STEMI patients. And ACE inhibitors, those are angiotensin-converting enzyme inhibitors. They start those within the first day too, unless there's a reason they can't. And if someone can't handle an ACE inhibitor, they might use an ARB, that's an angiotensin receptor blocker, instead. Oh, and one more thing. They usually start high-intensity statins early on too, like atorvastatin or rosuvastatin.
Gotcha. So that's the initial response. But what happens after? Like after someone's had an MI, what's the long-term plan?
Long-term therapy after an MI, it's all about preventing another event. That's called secondary prevention.
Yeah.
So almost everyone stays on aspirin indefinitely, or clopidogrel if they can't take aspirin. And they also usually keep taking a P2Y12 receptor inhibitor long-term. Doesn't matter if it was STEMI or NSTEMI.
Okay.
They also give them short-acting nitrates. That could be like a spray or a tablet for under the tongue. Those are for any angina symptoms that pop up.
And what about those ACE inhibitors? Those are for the long haul too, right?
Yeah, they usually keep taking those. That
Right.
helps prevent heart failure after an MI. They might also think about using aldosterone antagonists. They can start that in the first 2 weeks or so after an MI if the person has had heart failure symptoms.
Okay.
And they can stay on that indefinitely. Beta blockers, those are usually continued indefinitely too after ACS. If someone can't take beta blockers, they might try calcium channel blockers instead. Those help manage angina and blood pressure.
Right.
And then the last thing, cholesterol. Getting that under control is really important. Everyone with coronary artery disease needs to watch their diet, and they usually need meds too. Statins are the usual go-to. They want to get that LDL cholesterol, the bad kind, under 100 milli-GDL.
Wow.
Yeah, and these guidelines really push for aggressive statin therapy now. It's because we're understanding more and more how important that LDL cholesterol is, even after you've had an acute event. It plays a big role in long-term risk.
That's that was incredibly informative. I feel like we really covered it all. The different types of ACS, what causes them, how they show up, how doctors diagnose them, and the treatments, both right away and long term. It really shows how serious this is and how important it is to get the right medical help fast.
Couldn't agree more. It's really a whole spectrum of conditions. They all come from problems with blood flow in the coronary arteries,
Mm.
but how bad they are, that varies a lot. And that's why the diagnosis and the treatment, it's got to be tailored to the individual.
Yeah.
And yeah, how quickly they diagnose it and start treatment, that makes a huge difference for the patient.
The thing that really got me was how directly that blockage, how much the artery is blocked, that really determines which type of ACS it is. From that tiny clot in unstable angina to the complete blockage, the lights out situation in STEMI. And the medications, wow, those are powerful drugs. And they've got to be given at very specific times, the right doses in those first few hours. It really shows how far we've come with, treating heart problems.
Absolutely. And it's fascinating how they combine those immediate efforts, like doing a PCI to get the blood flowing again with the long-term medications to try to prevent another event. It shows that taking care of your heart health, it's an ongoing thing. It doesn't just stop after you've had, an acute episode.
Yeah. When you think about how complex ACS is and how crucial it is to act fast, it really makes you realize, people need to know about this. They need to recognize those symptoms, the chest pain, the other things that can happen, and they need to get help right away. I mean, that could be the difference between life and death.
I agree. Recognizing those symptoms early and doing something about it, not waiting, that can truly save someone's life.
Well, thank you so much for walking us through all of that. That was a truly incredibly informative deep dive. I feel like we all have a much clearer understanding of acute coronary syndrome now.
It was my pleasure.
And thanks to everyone for listening to this deep dive. We'll see you next time.